On behalf of the National Eczema Association, I'm pleased to welcome you to today's presentation, Eczema Myth-Busting, Misinformation and Unfounded Concerns. Our presenters today are Dr. Peter Lio and Dr. Joy Wan. Dr. Lio is a clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai and a clinical assistant professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine. He serves on the American Academy of Dermatology's Atopic Dermatitis Expert Resource Group and is a founding faculty member of the Integrative Dermatology Certification Program. Dr. Wan is an assistant professor of dermatology at Johns Hopkins School of Medicine, where she specializes in pediatric dermatology and atopic dermatitis. She also leads an active research program focused on epidemiologic and patient-oriented investigations of pediatric skin diseases, including eczema. And with that, I'd love to pass it over to both of you to start your work here.
Thank you, Brian, so much. I will share my screen and we get to myth busting, misinformation and unfounded concerns. So this is always a fun topic because we can dive into a lot of different pieces. These are Joy's disclosures. These are my disclosures. And let's start with the first one, myth. Foods cause eczema. Dr. Wan, do you want to start us out?
Yeah, I love busting this myth all the time. So I think this is probably one of the most common questions that I get in my practice, where a lot of families wonder if a specific food is the cause of eczema. So I guess maybe we can start by taking a step back first, right? What are kind of truly the causes of eczema? And I often like to say, well, there's a variety of causes of eczema. There's genetics and there's environment. And, food might fall under environment. We'll get to that in a minute. But, there oftentimes is not just one cause of eczema. So getting to kind of, I guess, this myth of, foods causing eczema, while it is more common that kids with eczema and adults with eczema will have other types of allergic conditions, including, food allergies, for example. Most of the time, foods are not the directly relevant trigger or the cause of one's eczema. And so oftentimes I try to tease this out with patients and families, right? And I'm curious always to hear about sort of what they've experienced with certain foods, kind of where are the symptoms that they are, witnessing that make them suspect that perhaps the food is causing eczema. And most of the time, what I can say is, there's not one food, right, that is kind of the trigger cause for the underlying eczema. Some people may notice that perhaps some foods, they're a little bit more sensitive to, or they might notice that the eczema flares a little bit more, with ingestion of certain foods. And in some situations, you can actually have a true allergy to a food that may cause other symptoms, beyond just eczema. But generally speaking, foods are not the direct cause or oftentimes, the direct trigger of one's eczema. But I'll start there and maybe you can expand on that, Peter.
No, I love it. I think you really you and I are right in alignment, and you hit on all the key points that I try to make to my patients as well. It's you notice you didn't say there's no such thing as this. There is such a thing as some patients out there who certain foods really do seem to make them worse. We're not denying that. It just seems like it's a pretty small minority of patients where that's the main driver. And that's why we don't spend so much time on it. I often tell patients, I wish it were. If it was that simple, you probably wouldn't be here today. You would have figured that out and said, every time I eat tomatoes, I flare up, so I don't eat tomatoes. Great. I would also argue, as again, you beautifully laid out there, it's like if a food or even a group of foods were the only thing driving your atopic dermatitis, your eczema, I would say that actually is an atopic dermatitis. Now you have an eczematous food reaction. So you have a different disease. And that's okay. That's great in some ways because then we can really figure out what's going on. But most of our patients, in fact, I would argue more than 90%, this is not that simple. And then finally, I love that you touched upon the idea that there's a lot of complexity around this too, because it's like some people truly have hives to foods, like a true food allergy. And absolutely, if you hive up and start scratching, that could trigger your eczema. So that's real. That's part of the story. But I think we'd all agree that's not explaining the root cause of the eczema. It's just another triggering event. Some people can have direct irritation from eating a food. Little kids, their face is often broken down and irritated. If you're eating tomatoes or citrus or something, that can irritate and break down the skin, but that's not an allergy, but it is in a way causing your eczema, but I don't think it's what anyone means, but it's important to separate that. And then we have some very specific diseases where foods are clearly driving it. So for example, somebody with celiac disease, right? In the skin manifestation of celiac, we've all heard that term. We know that it's to gluten, and it's specifically the gliadin on gluten that drives this very specific reaction. Now, those patients who have dermatitis or pediformis, it can look like eczema, but it's not. It's its own condition. So we have a whole set of things. And finally, the last big one that I like to talk about is inflammatory foods. I think if you're eating a healthy diet and avoiding processed foods, sugary foods, for some people, dairy kind of can have a pro-inflammation effect. All those things, you can affect the general trend of your disease. It's probably not the whole story, but it can make a difference. So we're not dismissing it. And I've had some pushback. Patients said, well, why do you make it sound like everybody's crazy when we talk about foods? I say, no, we're not at all. We're saying that it's not so simple. It's weird because people throw food under the bus and say, oh, we just got to find the food, but it's much more complicated than that. And for most patients and families, it's maybe like number 5, 6, or 7 on the list after some of the bigger things we want to do first because we're trying to get people better quickly.
I totally agree, Peter. And I think, one thing that you kind of touched upon too is that for every individual, it's very different, right? There is no one kind of pan cause of eczema or food cause of eczema for everybody. And people have different reactions or, have different kind of levels of relevancy with respect to kind of foods and their eczema, symptoms. And so it's really identifying, whether for any given person, there are some potential kind of food relationships or, kind of triggers or not, right? I would say probably more often not than there, but if there is, then coming up with sort of the ideal ways to address that. So I think absolutely kind of separating out causes of eczema from things that may influence it or trigger it or kind of add fuel to the fire, right? And some of the rashes that you had touched upon there as well, Peter. So absolutely, it's definitely something that I think a lot of people wonder about, but I think we can safely say foods are not the cause of eczema at this point.
I love it. Let's go to myth number 2. There's a magic bullet or even a cure for eczema. And if this were on the internet, it would often have the little admonition that they don't want you to know. What do you think?
Yeah. No, I wish this weren't a myth, right? If we had a cure for eczema, we wouldn't be here today, on this webinar. But no, there is no cure in the sense that, and by cure, I think, here I would, interpret that to mean something that can take away your eczema forever, right? We know that eczema is a chronic type of condition. That doesn't mean that we, don't want to get it under the best control, right? For any given person. And I think there are many ways that we can do that, but ultimately there's not something that we can, give somebody that would just cure them of their eczema for the rest of their lives. Now that being said, right, eczema is such a mixed bag of kind of disease course and trajectories and activity and severity, right, for different people. And so there are certainly cases where, for example, young children, right, who have eczema, some of them will kind of outgrow it, as we would like to say, where their eczema gets better and they almost sort of seem like they're cured of their eczema, right, because they no longer have symptoms of it once they're, in adolescence or into their adult years. But that being said, that's part of just kind of the natural kind of trajectory or history of eczema for some individuals. But for the vast majority of people for whom eczema can be quite chronic, it can be lifelong. There is unfortunately not, a treatment or any sort of intervention that can be done that would just take it away forever. And part of that, I think, comes from the fact that there's a lot of genetic drivers of eczema. There's also some environmental ones that can interact with the genetics, right, to kind of predispose someone to developing eczema or not. And so, unfortunately, there is no kind of cure to address those root causes. But what are your
I
thoughts, Peter?
Totally agree. And just for the listeners, we haven't talked about these beforehand, so you kind of are getting two independent thoughts. We're kind of reacting to these in real time. I just want to be clear, we're not, collaborating beyond that, but it's neat to see how we do converge. I feel exactly the same way, in part because I feel that eczema is not one thing. There's a range of reasons why people have it, the underlying factors, genetics and environment. So it would be weird if someone said, "Oh, I have a magic bullet. This will fix everybody." I'd be like, I kind of know before we talk about anything that has to be false because I don't think this is one thing. If you said I have one way to clean all stains from your carpeting, I'd be a little confused too. I'm like, well, a stain, that is dog poop is different than blood, which is different than tomato sauce. So
Right.
how do you have a stain that's going to be, maybe you can burn a hole in the carpet. That might be the kind of stain solution. But same thing here. If you have different underlying issues, some people it's primarily an immune problem, some people it's a skin barrier problem, some people it's probably more of a nerve issue. The nerves are hypersensitive. Many people have a combination. We know the microbiome is playing a role. So what would the shape of a cure be like? I think there isn't one. It's too complicated at this point. Now, in the future, I really think we're heading that way. One of the things that I've seen, we've both seen talk about a lot, is this idea that if you break this vicious cycle of eczema for many patients, what I find is we can reduce those treatments. And in fact, some of the newest treatments that are FDA approved have a built-in increased interval, meaning, for example, if we take one of the medicines, the one called nemolizumab, that's a newer one. It's a biologic that mostly targets itch, and it's built such that as you take that medicine, you start out every month, but if you're doing well, you go to every other month. You literally get half the dose. And the same goes for lebrikizumab and tralokinumab, two other biologics that each have ones that literally you cut the dose in half. That's amazing to me. That's a huge breakthrough to me because that literally says we're able to keep you just as good as you were for a long period of time on literally half the amount of medicine. So that's step one, decreasing. Step two is what we've seen some of our patients. Maybe a patient has to stop for whatever reason. Maybe they're going to try to have a baby. Maybe they're traveling extensively. Maybe they just don't want to be on medicine. I have patients say, I'm just burned out. I don't want to be on it anymore. And they stop it. And for some percentage of those patients, and I wish I could promise this for everybody, I can't yet, but for a sizable group, they actually stay pretty darn good for many, many months or even years after stopping the medicine. Now, does that mean they're cured? They still maybe have some sensitivity or some irritation or some itch. But one thing we do see is that people who are up here really severe, if we break that cycle and keep them better for a long time, even when you stop pretty much everything, many patients stay relatively better. And to me, that's another breakthrough, another step towards a cure.
Yeah, I am also similar to you, Peter, very optimistic that we will get there, in sort of the next, coming sort of, I don't know, I don't want to put a specific timeline on it, but hopefully within our lifetimes, right, that there will be, kind of some of these now available treatments and certainly emerging treatments that will really break that cycle, kind of, put people into, kind of borrowing a term from, other kind of fields, remission, right, where you actually are really free of your eczema and perhaps even free of it once you come off of any sort of particular treatment or intervention. And I'm really hopeful that we will get there. So yeah, certainly a myth for now, but maybe this will no longer be a myth at some point down the road with all the developments and research and treatment for eczema.
That's our dream, right? We would love that. And probably at that point, my dream is that we will have such good precision or personalized
Mm-hmm.
medicine. We'll be able to look at a patient and say, hey, look, this is exactly what's wrong. We are going to fix those things. We're going to fix your microbiome. We're going to heal your skin barrier. We're going to do this and this and that. And then they really will be cured. We'll fix the fundamental problem. I love that idea. And I was going to just add one of my favorite terms is this idea of the virtuous cycle of drug development. We give a lot of grief to drug companies. They're evil empire. They're just trying to keep everybody sick and on their drugs. Maybe I listen. There's a lot to say. There's a complicated issue, but the one thing I can say is that we are seeing things get better and better, and that to me means something. There is progress happening. What we had, and we're old enough. Well, maybe you're not old enough, Dr. Wong, but
No,
I've been
I
around long
am.
enough before we had anything. I mean, we were using the worst stuff. It was terrible. I remember feeling just sad when I had to give my patients a systemic medicine because they were not designed for the disease. They had tons of side effects. We knew we were causing harm, but it's like we were trying to cause less relative harm. Now we have so many better things. And I agree. We're not where we need to be yet, but boy, we're moving in that direction. And that's a big deal.
Yes, absolutely. All right, next myth. Bathing doesn't really make a difference. All right, you want to tackle that first, Peter?
Sure. I'll start by saying that this is a complicated myth. And really, as recently as I think last week on our dermatology Facebook group, there was somebody talking about a recent study. So this one, it may be difficult to bust because there's so much to it. But again, there's a lot to kind of dive into. The first thing I would say is that there are some really important issues around bathing that we need to address. First of all, if you bathe frequently with a cleanser that's harsh, like a true soap that's alkaline, and if you don't moisturize right after, you probably can make things a lot worse, right? Because water strips away a lot of our natural oils. Harsh soaps, especially ones that are alkaline, can damage our acid mantle and our skin barrier. They can rip up the skin barrier itself. They can really make a mess of things. And if you don't moisturize after, you can leave with a net negative of skin barrier damage and losing water from your skin. So that I think that's pretty clear. Most people would agree, especially with like a harsh cleanser, you don't want to do that. If you don't bathe a lot, which is kind of the old-fashioned advice, I think when the cleansers soaps were harsh and people didn't know that much, I said, bathe less frequently, only bathe once a week or every couple of weeks. That I think can be effective for some people. It's less disruptive, but then we end up with leaving sweat and bacteria and allergens and irritants on our skin. We also, I think, sometimes can actually push those in. If you moisturize over a lot of junk on the skin, you can actually kind of facilitate it, pushing it into your body, which might not be great. So to me, kind of the Goldilocks, and there have been a couple of studies. Admittedly, none of the studies are really great, but the one that I liked a lot was where they did this thing they called the wet method, where they had people bathe twice a day, and the dry method, where they had people bathe like twice a week, kind of thing. So kind of more frequent or less frequent. And the people who bathed more frequently in that study did much better. It was pretty impressive how much better they did. But they used a super gentle cleanser, so not a harsh soap, what we call a Syndeta, synthetic detergent that's designed for sensitive skin, and they had people moisturize right after. So I think if you do those things, I think that bathing can make a positive difference for a lot of patients. That being said, the more recent study that I just saw that was talked about in our group was that I think it was a British study where they showed people doing it more frequently, less frequently. It didn't really matter. So in some ways, they were kind of saying, actually, maybe this isn't a myth and it's real. Dr. Wong, what's your take and what do you tell your patients about it?
Yeah. Yeah. No, I totally agree with you. This is a complicated kind of myth to break down and kind of, there's so many different pieces, right, to address here. So bathing, in the sense that we're kind of using it in this myth, right, entails so many different components, like you mentioned, right? There's the frequency of bathing, there's the temperature of the water that you're using, right? There's the cleansers that you might be using on your skin. There, some people, I often will tell patients and families to not use washcloths or loofahs, things that can be rough on your skin, right? To kind of remove that kind of frictional component, right? So there's other these accessories, right, that one might be using in the bath. And then finally, we're talking about moisturizing right after the bath and those types of practices. So really, like when you lay it out, there's five or six different components to bathing. And I think that, again, there's not necessarily one of, these five or six that is going to kind of, make it or break it with respect to your eczema. But I think it's all sort of the components together, right? That one needs to kind of consider and needs to kind of make sure that we're doing kind of the most appropriate things for. So, I give actually, maybe surprisingly or not surprisingly, a lot of the same guidance to my patients, my young patients, in terms of bathing. And I really tell people based on some of these recent data that it's probably not frequency that makes the biggest difference, but it's how you do it, right? So when you do bathe, even if it is, every day for some of my young kids who are, out and about, in school, right, getting muddy and all of that, it's like they should take a bath every day to kind of wash some of those, kind of, so, kind of allergens, dirty things off their skin, right? You want them to bathe every day. In that situation, that's okay. And I say, well, you really need to, use the appropriate cleansers, right? Avoid any kind of frictional, accessories, washcloth, things like that. Just lather with your hands, and then you need to immediately moisturize with a very moisturizing cream or ointment, after you come out of the bath, like immediately after you come out of the bath. And I think, as long as you kind of follow some of those guidelines, right, then frequency doesn't matter so much, for example. So really it is kind of making sure that all of those kind of components are kind of thought through and that you're, using the most appropriate, products and following the most appropriate practices for each of those components.
I love it. So I feel like we can really bust this myth right away. Bathing definitely makes a difference. Although I think the secondary part of the myth of what are the specifics, we would argue that, yeah, there probably is some more room to learn and it may be different for different patients too. So
Yeah.
there's not necessarily a best bathing practice for everybody, but they certainly make a difference. The other thing I'll use this opportunity is a plug because we've mentioned sort of these broad categories of products, gentle cleanser, good moisturizer. What do we
Yeah.
mean? So my teachers, and maybe your teachers too, would sometimes literally just say that to the patient. Pick a gentle moisturizer, pick a gentle cleanser, and walk out of the room. And I think there was a time when that wasn't so bad because you'd go to a drugstore and there might be a few options and you'd probably be able to figure out which one. There'd be a couple. And you were probably okay. But now you go to a drugstore and there's aisle after aisle of different products. So it's like, which is good, which is not, which has evidence. And so the plug would be for the Seal of Acceptance program through NIA. The National Eczema
Mhm.
Association has this wonderful Seal of Acceptance program. There are a lot of products in there. So I promise you, you will find something for everybody in there, but you can access it by going to the website and you'll see it right up there. And you can actually, oh, thank you. Thank you. It's in the chat right now. I appreciate it. So you can find that and you can find products that I think, are they going to be great for everybody? No, of course not. There's hundreds and hundreds of products in here, but are they a good place to start? Yes. And you can try different things and see which one fits well with your skin because again, it can be an individual journey and that's really important.
Yeah, absolutely.
Eczema is
Okay,
just a
next myth.
childhood
Yes,
condition.
you
You'll
go ahead.
grow out of it. You mentioned this already, Dr. Juan. Tell us a little bit about this, especially a family saying, is this going to be lifelong? Am I going to grow out of it? Can I just wait? What if we just wait? Because maybe the baby will grow out of this. Should we not do anything?
Yeah. So, as we touched upon earlier, right, eczema is very common actually in children, and also quite common in adults. But it's estimated that when you look at kind of just the prevalence of eczema, that it can be up to 1 in 5 kids with eczema at some point, during their lifetime, right? And so it's super common, and it most commonly arises within the first few years of a child's life. That doesn't mean that some people don't develop it, until they're older, or even as adults. But certainly, this is the age group where we see eczema tend to kind of come out more commonly, and also sometimes to be a little bit more severe as well. So, kind of, getting to kind of the second part of that question, or this myth, right, that you'll grow out of it. I think that there have been some really wonderfully done longitudinal kind of long-term studies looking at population level data, right, for example, from groups of individuals from the United Kingdom, for example, and other countries around the world where they have followed children from birth, actually, and they have tracked whether they have had eczema over the course of their childhood and even into some adult years for some of these studies. And what they have found is that actually, surprisingly, a lot of children, they don't fully outgrow their eczema, right? As sort of we used to think about it, but they still have some eczema activity over time, and that sort of level of activity is quite variable. It ranges from, yeah, it's a nuisance, like sometimes I'll flare with it, to it's still incredibly severe, when I'm in my adult years. And you can be anywhere in between, right, on that spectrum of kind of persistent eczema. And so, really, nowadays, when families ask, well, is my child just going to grow out of this, or what's going to be kind of the long term? I say, actually, based on the data that we have, I don't have a crystal ball to tell you for your child, what is going to happen with their eczema, right? Are they going to outgrow it? Are they not going to outgrow it? How, if they don't outgrow it, how bad will it be? It's just really hard to predict. And I wish there were sort of ways that we can predict, and I think that's hopefully something that we can find in the future, right? That we can develop some of these more predictive kind of models or algorithms, and kind of know for any given child, like, what are the chances, right, that they might outgrow or not outgrow, and what are the chances of having more severe disease over time. But until we get to that point, I say we really don't have a crystal ball, unfortunately. However, I would say there is a fraction of kids who do outgrow it. There is a fraction of kids for whom it naturally improves a little bit, but they still live with eczema beyond childhood. And then there's yet, another group of kids for whom it can be quite persistent, quite severe, sometimes even increase in severity over time. And so, it's such a heterogeneous condition, as we talked about earlier, Peter. So yeah, that's sort of kind of my take on this myth, is that certainly it's not just a childhood condition, and certainly we know plenty of people will not grow out of it per se. But what are your thoughts, Peter?
Absolutely agreed. I think the other piece that's been really interesting to see is the development of eczema in adulthood. So I have a fair, I see adults and kids, and I have a
Mhm.
fair number of patients who developed it new as adults. And what's wild is that when I trained, they were very rare. And I remember one of my teachers saying, I think this is a different disease. I don't think this is atopic dermatitis as we know it. When adults get it who didn't have it as kids, this is something strange. But now we have so many adults like this that I think it might be different, but it's part of the spectrum and it's very strange. The other piece, I give a lot of credit to Dr. Ian Miles. He helped popularize this concept of some of the environmental triggers of atopic derm. And some of the early work was looking at people who were exposed to wildfire smoke. So adults who had no history of atopic dermatitis, they were exposed to wildfire smoke nearby. Even if the fires could be hundreds of miles away or thousands of miles away, but the smoke was hitting them, there was an increase of new onset atopic dermatitis in adults. So this is one of these interesting epidemiology findings. So many of the big breakthroughs are from epidemiology. People say, wait a minute, I see a pattern here. This is weird. And then Ian Miles and others have looked at this and they found that one of the chemicals in wildfire smoke is a group of chemicals called diisocyanates. And this is poisonous to our microbiome and damaging to the skin barrier and actually seems to be a huge independent risk factor for developing atopic derm. So it's not just a childhood condition. We can bust that myth on many accounts and you might not just grow out of it, unfortunately. And I think we can put this myth to bed.
Yeah, agreed. Okay, next myth. If you have eczema, your kids definitely will too. You want to tackle this first, Peter? What do you think?
Sure, I think that we can bust it right away. We definitely cannot predict with any kind of definitive nature if someone's going to have it, but we do know there is a risk factor that is increased. And I think the math is a little tricky. So I usually tell families if they have one parent with atopic dermatitis, there is an increased risk that the children will have it. If there's two parents with it, or with some of the other allergic conditions like asthma or bad hay fever, it's true that number goes up, but it is nowhere near 100%. And it is definitely one of those things where I have many patients who had severe eczema and their kids are totally fine so far. I've watched them for the first 5 or 10 years of life. What do you usually say?
Yeah, I totally agree. Again, we don't have a crystal ball here, right, to predict whether children, whose parents have eczema are going to also develop eczema. And I've seen everything, sort of across the spectrum, right? There are certainly some kids that I've seen who have severe eczema whose parents also, one or both of them also had quite severe eczema or other types of related allergic conditions. And then there are also some kids and they're the only person in the entire family to say have eczema or severe eczema, for example. And so we know that genetics are not they don't always determine the outcome here. And also genetics works in such a weird way, right? Eczema, when we talk about kind of the genetics of eczema, it's not a condition that's directly inheritable like some other genetic conditions are, where it's sort of like you can kind of predict, with statistical kind of, accuracy, right? If one parent has this, another doesn't, kind of what are the chances that my child is going to have X condition? Eczema doesn't work like that because there's not one gene, that causes eczema. There's so many different genes that do.
And I love that you bring that up, right? Because exactly right. If it were as simple as just a genetic disease, then we would be able to predict it. There are some diseases where you can literally make the Punnett square and say, okay, 1/4 of the kids or
Yep.
half the kids. But we this also really helps us understand it's not just genetics, and that's kind of how we know because you can't predict it.
Exactly. Exactly.
Okay, you should avoid topical steroids at all costs. And I meet a lot of families who start the visit this way that they don't want to touch any topical steroids. I'm sure you do too. Talk to us about topical steroids, Dr. One.
Yeah. So topical steroids, though, sometimes controversial, and there's a lot of mixed information about them right out there that families, can read about. For me, topical steroids are still a very, accessible and very generally, when used in the right way, very safe type of treatment for some people with eczema. And so I would say still, for myself and a lot of, colleagues, topical steroids are still the first line treatment for eczema, right? Now, that being said, right, it's not as simple of sort of just saying, okay, just use topical steroids, right? We also have a lot of other non-steroidal topical medicines now at our disposal, which is fantastic. And I think we have to use all of them, right? Both topical steroids and non-steroids in the appropriate ways, right? And use them judiciously. So with topical steroids, I think that if you are using them in the appropriate way, and maybe I'll let you, clarify and further elaborate on, kind of what we mean when we say appropriate, right? But if you're using them in an appropriate way, they can still be very safe and very effective for eczema. And so for me, some of the ways that I counsel families and patients about using topical steroids is, certainly as the healthcare provider, we're selecting topical steroids that we think are going to be safe for the areas that they're going to be applied to, right? For the kind of amount of area that they're going to be applied to. And we also spend a lot of time counseling families about, how long do you use these for? How long of breaks should you be taking? And the like. So those are some parameters that we really have to be very explicit about to make sure that we aren't running into potential side effects. Because yes, there are potential side effects with topical steroids if they're used in inappropriate ways. But Peter, you jump in here and fill us in more too about your thoughts.
Yeah, this has been something that I've really focused on in the second half of my career, and most of my work is in this domain, trying to understand this topical steroid withdrawal and some of the other side effects from
Yeah.
steroids and non-steroidal approaches. So I'm obviously in team minimize steroids, but even I don't agree with this myth. I think we should bust this myth because topical steroids are still really important and they help a lot of patients. And I often think about it, it's imperfect analogy, but it's real. Like swimming pools are actually pretty dangerous. They're one of the things that cause a lot of harm to children. We could say swimming pools are bad, ban them all, and people would be safer. Probably they would be, but it'd be a huge loss. Driving, car accidents are a huge problem, right? I mean, it's one of the biggest killers in the United States and across the world. You could just ban all cars. I mean, we'd be safer, but it's like, I don't know. I feel the same way about steroids, right? They are far from perfect. They have a lot of dangerous aspects of them, but it seems sad to throw them out completely because millions and millions of people for since the 1950s have used them with tremendous relief. So I feel like it's one of those things where good stewardship, deep understanding, and being very honest and open and transparent to say, listen, hey, these are not perfectly safe, right? Nothing's perfectly safe. And in fact, they're very powerful. So we know they're not perfectly safe. But if we use them carefully and we're paying attention, we can get almost everybody to use them with good effect. They're very inexpensive. They're very widely available. They're very reliable. I talk about this idea of reliability, meaning some medicines we give to a patient and we're kind of like, I think it'll work. I hope it'll work. And it doesn't work. Like, yeah, it didn't work for me. It irritated me. It bugged me. It didn't help my skin. I have that a lot, especially with some of the safer choices. Like they can be great fits for some, but they're not great for others. Steroids help almost everybody, which is really neat. So we kind of have a predictability of it. But if we feel like we're using them too much or people have been harmed, then for sure we're going to avoid them and we're going to cut back on them. And thankfully, now again, I'm old enough to remember a time when we had very little outside of steroids, but now we have lots of things outside of steroids. And I remember one of my teachers, he passed away a few years ago, but he used to tell us he was in practice before topical steroids were widely available in dermatology. So like in the late 1950s, they still were not, you couldn't really get them. We were like, Dr. Michelle, what would you do? And he's like, a lot of petrolatum. They just, a lot of moisturizers, they just didn't have much at all. So I think people just suffered. And that's the truth for many
Yeah.
conditions where we don't have good treatments. Suffering is out there, but our job in theory is to help alleviate suffering. So that's why, right? I mean, there's no big steroid. Nobody's paying us to use steroids, right? They're inexpensive. They've been out for a long time. They're off patent. So it's like we're just trying to use them with good intentions for the most part. But do people get hurt from them? Absolutely, right? Are there serious side effects? Absolutely. We would never deny that. But under the care of somebody who's really doing their best and watching you carefully, can they be used safely for most patients? Absolutely.
Yeah, totally agree. All right, next myth. Every flare must have a clear, identifiable trigger. Well, what do you think, Peter? Is this something that you can bust?
Bust that myth. I wish they did. I really do. It'd be so cool if it were that clean. But right, I feel like in my experience, the vast majority of the flare-ups have no clear trigger at all. I like to ask because sometimes you can find things
Mhm.
that are contributing, but it's so rare for someone to have a really clear, systematic thing that we can figure out. And there's so many variables, as we've said. The weather is a huge variable, what you're exposed to in the air. You might not even realize you're walking around a place where there's something. I have to tell one story. This is an old man story, but it was a wild situation where this patient her face and neck were just so bad. And this is a big part of my practice. I have a lot of people where face and neck dermatitis is just
Mhm.
so challenging and resistant and tough to control. We did these things and we did patch testing on her again. She had had it years before. It wasn't that helpful. We did it again and it kind of said the same thing. She was allergic to fragrance, which is a big group. And she's like, I guarantee you, I promise you, I don't use any fragrance products. And I even talked to her about people she's with because sometimes, people, if they're
Mhm.
close or hugging somebody who's wearing fragrance, that could be enough. So on. We couldn't figure it out. Anyways, finally, months passed. We tried all these things. She came back and she said, I figured it out. And her face and neck were clear. And I said, tell me, what was the answer? And she said, every morning I would go to work, I would cut through this shopping mall and there was a perfume counter. And it dawned on me one morning as I was sneezing, as I walked past it, and I thought, maybe. So I just changed my route. Now I go outside and my skin is clear. So it was the wildest thing. That was such an experience. I'll never forget it. But that was like the one, right, of my career for over 20
Yeah.
years in practice. That's the one. So that flare had a clear trigger, and I love it. I covet that day. I wish everyone were like that, right? It was the best day. But 99.999% don't.
Exactly. Exactly. Completely agree. People can have some triggers here and there, but every time that your eczema occurs, more often than not, it wasn't something that you were exposed to just before then, right? But I certainly, just like you, I always ask still. And I still always, every winter season, get an influx, right, of kids coming in because all of a sudden their eczema is flaring and they need refills, or they, kind of need to get back on some stronger topicals, for example. And so for those kids, it's like, I know, okay, all right, every winter season, you might get a flare that probably was triggered by the cold weather. But more often than not, they also flare other times, maybe not to as bad of a degree, right? But even when those triggers are not present, they can still flare. So absolutely, I think this myth is absolutely busted. Not every flare is going to have, identifiable trigger that we can just easily remove. So I love that story though, Peter. You know,
It was one for the books, right? Yes, it was a great
yeah.
one. All right, so that concludes, thank you for your attention. That concludes the kind of didactic portion. Now we have time for questions.
Thank you both for that discussion. That was eye-opening. Thank you for breaking those myths. Um, but yeah, as you said, now we want to pivot over to our community and answer some of the questions that they've asked. And so starting with our first question, is it true many kids who are considered outgrown of their eczema end up getting asthma? Or talk about those comorbidities?
Yeah. I'm sorry if my internet went in and out for a minute there, but I can uh, start to tackle this first, and then maybe Peter can jump in. So, we always sort of, when I was in training, would learn about kind of this model of the atopic march, right? And people in the audience may have also heard of that as well. And we sort of, alluded to this earlier, that people with eczema, they are more likely to have other allergic types of conditions, right? Food allergies, asthma, seasonal allergies. And so kind of this atopic march model, sort of proposes that eczema is kind of the first hit. You have eczema, and then that, through kind of the skin, also exposes you to other allergens that then kind of prime your immune system to become sensitive to things in our environment, such as food or other environmental kind of exposures like pollen or whatnot, that then kind of instigates the development of asthma and then seasonal allergies at older ages. And then we also kind of touched upon already, right, that for some individuals, eczema kind of can wane over time. They can become a little bit less active, and even with some people outgrowing it. And so, absolutely, we do see people for whom, they had eczema when they were younger, maybe even outgrew it or had a lot of improvement in it just naturally. But then later on, also went on to develop asthma or seasonal allergies or some other types of allergic conditions. And I think, that can occur because a lot of the same genetics that drives these conditions are the reason why they overlap a little bit. And so not everybody follows kind of this march, where eczema is always the first thing that happens, and then you get asthma or seasonal allergies. We know plenty of, people for whom eczema might occur after they already have other types of allergies. We also know that some people only get asthma, right, and never had any preceding eczema, or only have seasonal allergies and never had any preceding kind of skin issues. And so, everybody's a little bit different, and it's such a heterogeneous and mixed kind of bag in terms of all these types of overlapping allergic conditions. But absolutely, probably genetics. Underlie some of these kind of trajectories where you'll outgrow your eczema, but then you later on develop asthma or develop seasonal allergies or still continue to have, persistence of some of those other allergic conditions. Any thoughts, Peter? Additions to that?
No, I really like that. And I just think in my practice, it's actually pretty rare to see people go on to develop asthma. So I think that we could bust that myth of everybody going on to, or many kids going on to develop it. But some do for sure. It's just not many.
Excellent. And then we have another question. If you have nummular eczema only on limbs and trunk, does that give any clues as to cause? Can mold exposure cause this?
Mold exposure can do a lot of things to our body. Most of the stuff for mold really is respiratory, though. When we really look at it, it's because we're breathing in the basically the spores or the mold itself or the antigens. So it usually is more respiratory, but certainly because it's driving allergic type inflammation for some people, it could cause eczema flare-ups and skin flare-ups. There are these kind of whole sets of things that can surround it. But I would say if it's just nummular eczema, probably not mold directly, or at least is the main thing. And maybe it could be something helping kind of making it worse, but that wouldn't be where I'd look. For me, nummular eczema often has a big component of staph bacteria. There's often a heavy load of staph bacteria. So sometimes we find nummular eczema can be difficult to treat if we just use anti-inflammatory stuff. We find that we often need to fix the microbiome a little bit too, and it can be very stubborn.
Yeah, I agree. I've seen sort of similar in my practice that nummular eczema can be very, persistent and stubborn. And a lot of times you'll see kind of these really kind of, thick kind of areas of eczema, nummular eczema that then also has, you can visibly tell, that there's sort of extra bacteria on top. And so absolutely kind of addressing the nummular eczema from all of those angles is really important. And the thing with nummular eczema is that it can happen anywhere. So, with its localization and your particular question here, Sharon, on limbs and trunk. I mean, that's not unexpected. That you could just have nummular eczema in those areas without those areas being a clue to specific exposures and things. Just because it's so variable in terms of the locations where you get nummular eczema.
Our next question comes all the way from Sarah Neovo. Do you think that using steroids often as a part of therapy could be the reason why adults might struggle with eczema worsening and additional complications, including skin infections as years pass by? As we know, steroids thin the skin and lead to atrophy. Also, what are your thoughts on TSW as a condition that develops in some individuals after using steroids?
Yeah, I mean, that would be a whole additional webinar, which we can set up. There's great questions and there's a lot in there. I think, yes, it is possible. If you do overuse steroids, you can damage your skin and you can damage that barrier over time. I think that so it could be for some adults for sure. I think I do though have patients in my practice that have actually never used steroids at all. And have some patients who have never had vaccines, have never used all sorts of different types of medicines from when they were babies. Like but they still have really severe eczema, because I have a practice where I do also some alternative medicine. So some people will seek me out who've really kind of avoided all conventional medicine. And I can say there's a great quote from David Hume: "No amount of observations of white swans can allow the inference that all swans are white, but the observation of a single black swan is sufficient to refute that conclusion." Right. So I can tell you, I have some people who have really severe, in fact, some of the worst eczema I've ever seen, who've never put a steroid on their skin ever, ever, ever. So there's something to it, I think, beyond that. But yes, it is hard to know for sure. And again, I think it really pushes us to say we have to be good stewards of topical steroids. We don't want to abuse them. We don't want to overuse them. We want to be cautious about them and all of our medicines, right? We want to try to get the least amount of medicine to get people better.
Yeah, completely agree. I think sometimes it's hard to tease out, right? What are the triggers or the cause for why your eczema is now worsening, as you're heading into adulthood? And we know that eczema, right, as we talked about earlier, the trajectories are so diverse and unpredictable, for any given person that, yeah, there are certainly individuals. I don't really see as many adults in my practice, but certainly even older kids for whom all of a sudden, their eczema was super mild when they were younger. And then all of a sudden it starts to flare. And part of that, could also just stem from the fact that that's their intrinsic eczema, kind of behaving in sort of its natural own way, So yeah, definitely agree with you, Peter, that we still have to be good stewards of all of these, medicines that we use for eczema for sure to try to limit anything, any side effects that we can.
Great. And then we have another question. Norwegian mother of girl 15 with eczema here. Loved your myth busting. Thank you. Any short list of tips for motivating my daughter mid-puberty to take her condition seriously and keep moisturizing, and or any immune therapy to suggest?
Yeah. I love this. This is a common, I think, question that I get from parents of, kids around this age where, they're really sort of the age to start taking ownership, right, over their own medical care and certainly their skin care and things like that. So part of it, I think really stems from kind of how she might feel affected or not affected by her eczema, right? And I often try to have a conversation with my pediatric patients kind of one-on-one too, right? I mean, obviously the parent can be in the room and everything, but we often try to engage on a level with the kids, right, to try to understand like how their experience of their eczema is, right, what about their eczema is bothersome to them or not bothersome to them, and we try to identify like for them, right, what would be personally motivating, what are the aspects of their condition that they would feel more compelled, right, to address, right, and I think starting from that, you'll get a better sense for what might be more motivating for her in terms of caring for her eczema, and then help you to build in ways, right, to kind of be more consistent or adherent to whatever the plan may be, whether it's moisturization or other types of therapies like immune therapies like you were mentioning. And then for relate to this is one of the common questions that I get are from parents of, especially I feel like adolescent boys who they say, well, they just don't want to put their moisturizer on, but we know that it would help them, but I just can't get them to apply it, right? And so for especially teens of that age, most of them have a device now, right? A smartphone or something that has an alarm. And I often say, well, then just set an alarm, right? It's so easy with technology these days, right? Where again, if the issue after you have a conversation with the child about it is because they just forget, then set an alarm right on your phone, like their phones are always with them, right? So that could be an easy fix, right, if you can understand what the underlying kind of hesitance or the kind of challenge may be. There may be other challenges or other reasons why they're not kind of adherent to things, but really first you got to find out what it is before you can kind of come up with a more tailored approach to overcoming it. But we'd love to hear what you do in your practice period, motivate kids and patients.
Couple things. I love everything you said there. I think if the moisturizer itself is unpleasant, looking to find a good solution that they like. So lightweight
Right.
moisturizers, spray moisturizers. There are a couple of ones that actually come in a can. Even stick, they're like stick ones that can be easier for some people. So trying to find one that's cosmetically acceptable is a big deal. If people hate the feel of it, they're less likely to do it. The other thing I think that can be nice is calling it their work. This is part of your work. This is your job. And, connecting it with, I don't know, some kind of a system with like little marbles in a jar or stickers or something to even, it sounds like a little bit something you do for little kids, but I think older kids respond to it. Teenagers respond to it. It's like you can build up, if you do this consistently, this will get an award or a prize or something of value. And I think that's nice because it really is. It's going to help everybody. It helps them, but it helps the family too, because if the patient's suffering and you're going to the doctor more and more and they're not doing it, it's wasting everybody's time and energy.
Yeah. Yeah. I think having that conversation with the kid and really bring them into the fold, right? About making decisions, kind of identifying what their goals are, right? I think a lot of times it's easy for providers maybe just to talk to the parent, right? Because they're kind of technically the legal decision maker. But, if you can have that conversation with, between parent and child or between the provider and the child, right? To really understand like, what is the child's goal, right? In treating their eczema, then that really helps you to tailor kind of what approaches to go forward with. So
I a great
Yeah.
comment came in. I see here. If it's about simply forgetting, having them incorporated at the same time that they're already doing something. So, like brushing teeth, that's a great way to do it. It can kind of make it a habit. I think that's a wonderful concept to pair those things we want together.
Absolutely. Our next question is about from an eczema adult about eczema throughout kind of the lifespan. I've had AD since infancy, and now I'm in my 50s. It's changed so much over my lifetime. Initially presenting in the front of my elbows, behind my knees, and over the years it's traveled all over my body, including ears, inside and out, eyelids, face, scalp, neck, feet, hands. It's like a completely different condition at various points in my life. Is there any explanation for this?
Yeah. Peter, do you want to tackle that or?
I'm looking to see if I can read it again. Can I,
I
is
can
it,
put it in the chat.
thank you. I just want to read through it a little bit more carefully. There's a lot going on there.
Yeah.
Thank
I,
you.
I get the sense that things are just have been very unpredictable and things have changed so much over the course of, right, of one's kind of life, in terms of kind of locations and everything. I would say that eczema is such a heterogeneous condition, that yes, it could possibly still just be your eczema, right? Kind of doing this, changing over time in terms of location, in terms of its activity and severity. But I think also if you have noticed, a change, and I think if you were to come and see me, in my practice, I would probably, try to do my due diligence in identifying whether, A, is this still your eczema? And B, is there a reason, right, for this change, right? As Peter and I were talking about earlier with the myths with respect to flares and triggers and things like that, right? For some people, there are some triggers, that might induce kind of a change in their eczema disease course. And if we can identify it, great. Sometimes there may not be a trigger, right? So I think it still sort of is worth thinking about. Kind of, is there something that could explain or been a partial driver of this kind of evolution of your eczema? Is it still eczema, right? Is the other question. And if you've sort of, kind of done your investigative work on those ends, then I think, at the end of the day, if there is really nothing that we can find, sometimes it is still the eczema and it can do that on its own. What are your thoughts, Peter?
Yeah, and I think that we know that there are different age-related patterns of eczema. So in babies, it tends to be in
Right.
certain areas, in kids, in adults. So it does change, and we think that is probably related to hormones, probably related to the microenvironments on our body, how we sweat, the amount of oil we produce, and then of course, even things like the kind of the lifestyle we're living, the personal care products, and the behaviors we're doing. All of those things can affect these different factors, so it can present differently.
I think we have time for about two more questions. The first being, what's a myth that even well-meaning doctors sometimes accidentally reinforce?
That's a good question. I'm trying to, think about what might be the most common kind of myth. Um, I think that, and again, this is something that I feel like is probably, out there in the popular kind of media or people read about it, and so that's probably also why it gets kind of propagated still is one of the myths that we talked about today, right, is that like you'll outgrow your eczema, right, or it's not a big deal, right? That it's sort of a nuisance, but like you can live with it, right? And so again, obviously, I think for Peter and myself, and probably I would hope that most dermatologists, right, like we are sort of in a specialty where we know that that is absolutely a myth, right? But there may be providers who are in other fields for whom eczema is sort of like, oh, well, it's just eczema, and no big deal, you'll probably outgrow it, that sort of a thing. And so I think that that's one myth that we can absolutely bust, right? That has tremendous impact on people, and we also have a lot of treatments now, and hopefully even more to come, right? That allow us to be able to effectively care for somebody's eczema symptoms and to make them feel more comfortable and just have improvement of their eczema to a degree that we absolutely can and should be doing things about eczema. in our practices. So
The other one I would just add is, again, even from well-intentioned people, they'll be like, well, the only treatment for eczema is topical steroids. That's the only thing you can use. That's the only thing in our toolbox. And I'm like, it's not. But people don't often know about all the new treatments.
yeah.
Yeah. And then our last question. I keep seeing people online say healed their eczema from inside out. Is that real or is that marketing?
I mean, I'd love to believe that some patients do get better, and we know we've already said that that happens to some people. So I think that some people really do get better, and then they evangelize about it and tell the world about it, and that's fine. It just stinks for the people who have something different or it doesn't work for, and I think it can actually make some of the other patients feel even worse. It's like, gosh, this person figured it all out, and it just ended up being, I don't know, the gut. They had to do the gut testing, or it was heavy metal chelation, or whatever it happens to be, because those things are rarely one of the conventional treatments. You're usually talking about something unconventional. And again, I live in that world. I'm very interested in that. I'm an acupuncturist as well. And I truly believe there are things out there that can help. But in my own experience with these other things, almost never can I cure somebody. Again, I often tell my patients, my ego is less than my desire to get you better. So if there was something out there, I would send you. I mean, I refer patients routinely to acupuncture and traditional Chinese medicine and to naturopaths. I work with them. And I can tell you, we work together. If they had the solution, the secret, they wouldn't come back. But the reason I'm so busy, the reason it takes so long to see me, I don't advertise. It's because people are not where they need to be. So we have to keep trying stuff and working together.
Yeah.
Yeah, awesome. Thank you both so much. Dr. Rand, Dr. Lio, thank you so much for helping us separate these eczema facts from, eczema fiction. And thanks for everyone who joined today. We'll be sending a recording of today's webinar to all the registrants within 2 days, so keep an eye on your inbox if you'd like to revisit this discussion or share it with others. In that same email, you're also going to see a brief survey. Your feedback really helps shape the future of these webinars and addressing what actually matters to you most. So please, if you have time, fill that out for us. And you can continue your eczema learning at nationaleczema.org, where you'll find our trusted resources, upcoming webinars, and recordings of past sessions. You may register for future webinars at nationaleczema.org/webinars. And so, yeah, on behalf of the National Eczema Association, thank you all for being here, and we look forward to seeing you at a future NIA event. Thanks, everyone.